discuss in detail the postoperative tracheostomy care. These can broadly be discussed under several headings, and these include nursing care, fixation of the tracheostomy tube, removal of secretions, humidification, changing the tube, care of the inflatable cuff, dressings, and removal of the tube. Nursing. We must realize that the patient cannot talk because the larynx has been bypassed, and therefore the patient should be given a erasable slate or a book and pen in which to write and communicate, and a bell with which to summon assistance. The nurse must also wear a mask to protect herself and to prevent infection from happening. Fixation of the tube. One must realize that the tube has to be fixed by tapes tied around the neck. Two precautions. Number one, the knot has to be tied by flexing the head so that the knot does not become loose when the head is extended. Number two, the tie should be at the side of the neck. It should not be too tight, and the knot should be not to tie in a bow, since this can become undone. Again, the head should be flexed while the knot is placed in order to make sure that it does not become loose when the head is extended. In order that the knot do not poke into the neck, it should be placed at the side of the neck. Removal of secretions. After tracheostomy, since the trachea is exposed to cold air and the tube acts as a foreign body, it stimulates the formation of secretions, and during the first 48 hours, these should be systematically removed half-hourly. Thereafter, every 1 to 2 hours. The nurse should wear sterile gloves. A sterile rubber catheter is attached to one limb of the Y-shaped plastic connector from the suction apparatus, and the sterile catheter is inserted into the tracheostomy tube by means of a sterile artery forceps. She then places the thumb over the open limb of the Y-shaped connection to close the air entry into the suction apparatus and withdraws the catheter. This maneuver should not take more than 10 seconds, or else the patient will be rendered hypoxic. This maneuver has to be repeated until no further secretions remain. Now, as you know, the upper airway passages are the best humidifiers, and when this is bypassed, it is essential that the inspired air is humidified. This is necessary to prevent crusting of the secretions, and is done most simply by instilling normal saline down the tracheostomy tube at regular intervals, or placing a gauze soaked in saline across the inspiratory passage. Humidifiers are now inexpensive and widely available and should be used constantly. Changing the tube. The track takes at least 48 hours, and therefore the tube should not be disturbed. There are patients who have died when the tube has been removed in the first 24 hours because the track collapses and it is impossible to get the track back. As a consequence, during the first 48 hours, the tube should not be touched. Thereafter, the tube is to be changed daily and cleaned at regular intervals. On inserting the tube, it is essential to check that it is in the trachea and not lying anterior to it in the mediastinum. And if this happens, respiration will not be heard through the tube and vascular erosions may happen. So be careful while changing the tube, and when changing, make sure that there is a tracheostomy dilator available nearby. Now, care of the inflatable cuff. With the advent of low pressure cuff, one need not be as careful, but these cuffs should be periodically deflated to prevent lateral damage. Dressings. Waterproof squares are made which protect the surrounding skin from maceration from secretions and the movement of the tube edges, and these dressings should regularly be changed. Removal of the tube. This presents no problem in the adult. The tube is removed once the patient can sleep overnight with the tube blocked. The wound should then be freshened and sutured to prevent scar formation. In children, it is very much more difficult to remove a tracheostomy tube that has been present for more than a few days. At that time, initially, it was discerned that this difficulty was psychological, but it is now thought that the subglottic region above the trachea acts as a sump, and that subglottic edema occurs. Now, this is avoidable by using the Reese-Bracey tracheostomy tube, which is fenestrated and valved so that when the patient exhales, air goes up through the larynx, thus blowing out any secretions which are stagnating in the subglottis, which is the tube the Rees Precis tracheostomy tube. The various focus that one should have in caring for a tracheostomized patients, and these include nursing care, fixation of the tracheostomy tube. As I said, the knot should be placed by flexing the head, and then the knot should be placed on the side of the head. The removal of secretions periodically during the first 48 hours, it should be half hourly, and thereafter 1 to 2 hours, every 1 to 2 hours, with absolute aseptic precautions. Humidification to ensure that crusting does not happen. The tube should be changed only after 48 hours. The inflatable cuff should be taken care of. The dressings must regularly be changed, and finally, when it is appropriate, the tube has to be removed.